not favorable, hostile, right? They are not very friendly environment. When things are not friendly, what will happen? Baby will have some stress hormones producing, and they will try to compensate things, right? One of the problems that they get when they have growth restriction is hypoxia. When the babies are hypoxic, they produce this enzyme called what? Erythropoietin. Right. When you produce erythropoietin, what happens? Babies will have increased red cell production. So they will be what? Polycythemic. Right? They will be polycythemic. So small for gestational age is associated with anemia. Wrong. It is not associated with anemia. It is associated with polycythemia. That is why it is wrong. Right. Which babies characteristically have anemia as a complication? Yes, anemic babies will be the consequence if the babies were born preterm, right? Preterm babies are at a risk of getting anemia, but not small for gestational age babies, right? Small for gestational age babies, what they get is polycythemia due to hypoxia causing erythropoietin secretion, right? Hypoxia causing erythropoietin secretion, right? Hypocalcemia is a feature. Hypocalcemia is a feature. Small for gestational age babies can have hypocalcemia. What do we think? Is that correct or wrong? What do we think? Small for gestational age can cause hypocalcemia. Is that true? Yes. Small for gestational age occurs due to multiple problems. One is placental insufficiency. So nutritional inadequacies can cause all these deficiencies. If the mother could not transfer enough calcium to the baby from the placenta, say mother was malnourished, mother was hypocalcemic, you name anything, so then baby will end up in nutritional deficiencies. One of those nutritional deficiencies is what? Hypocalcemia. Future risk for metabolic syndrome is high. Is that correct? IUGR babies, right? I don't know whether you have heard of this concept called early programming, right? Early programming. When you have IUGR or small for gestational age intrauterine insults, that can change the hormonal pattern that the babies are going to have or the children are going to have when they are grown up, right? So IUGR children, multiple research, meta-analysis you name, they have proven IUGR can cause high risk of metabolic syndrome in the future, right? So this statement is correct. Normal head circumference at birth suggests asymmetric growth restriction. Now, what does this mean? Normal head circumference. Now, IUGR or small for gestational age primarily means that their growth is not satisfactory. What we mainly check is the weight. Suppose you have checked the weight is below a certain value and say less than 10th centile, right? Then you check two other parameters. What are those? The length of the baby when they are delivered. Length is the term we use up to 2 years. After 2 years, it is the height, right? So the length, right? Length could be small when the babies are born with intrauterine growth restriction or small for gestational age, right? Also, we can check their head size. Head size is an indirect indicator how their brain growth was, right? How their brain growth was. There are some babies whose weight is low, length is low, head is also small, right? Head is also small. Now that is called symmetrical growth restriction. In symmetrical growth restriction, everything is small, right? Symmetrical growth restriction, everything is small, including the head circumference. This occurs when you have the intrauterine insult starting right at the beginning of the pregnancy, right at the beginning of the pregnancy. Say, first trimester, mother had the rash and fever. You found that she had a congenital infection, you name rubella, whatever, right? So then the insult will start right at the beginning. Then what happens? The babies will end up in having small body, small head. Then that is called symmetrical IUGR, right? Whereas there are some babies who get growth restriction towards the latter part of the pregnancy, say third trimester, right? End of second trimester, like what? Say maternal hypertension, right? Maternal hypertension, pregnancy-induced hypertension. Then the placental insufficiency happens towards the latter part of pregnancy. By that time, the brain growth is satisfactory, or the body will try to make sure that they give everything to the brain, right? Rest of the body will compromise, but the brain will be spared. In that case, they will have a good sized brain or a head, and the rest of the body will be small. So that is called what? Asymmetrical IUGR, right? Asymmetrical IUGR. So normal head circumference at birth suggests asymmetrical growth restriction. That is correct, right? That is correct, right? If you are to get, right, a baby, right? So we don't hope anyone to get a baby with IUGR, right? But if you did not have any option, right, you have to choose your baby to be symmetrical IUGR or asymmetrical IUGR. Which one will you choose? Symmetrical or asymmetrical? Yeah, we would like to have at least asymmetrical IUGR, because why? Their head size is fine, right? Which means their brain is good. They will not have developmental problems, cognitive impairment in the future, as opposed to the babies with symmetrical IUGR. Right? Was that understood? So the answers are SGA, body weight less than 10 centile is correct. Anemia is an early complication, wrong. Hypocalcemia is a feature, correct. Future risk of metabolic syndrome is high, yes. Normal head circumference at birth suggests asymmetrical IUGR or asymmetrical growth restriction, correct. Right. So it is true, false, true, and true. Right. You know, in the exam, every wrong answer will carry -1 mark. Every correct answer will carry +1 mark. The maximum mark that you can have for a true-false question is 5 out of 5. Right. See how many marks you have got. Right. Right. So this is small for gestational age. Babies with birth weight below 10th centile for their gestation is known as small for gestational age. Right. Small for gestational age, or SGA. Small for gestational age infants may have grown normally but are small, or they have experienced intrauterine growth restriction, right? So anyway, we know what intrauterine growth restriction anyway, right? IUGR is associated with increased risk of intrauterine hypoxia. This also can cause intrauterine death, asphyxia during labor. The baby will be hypoxic at birth, right? And they also can have neonatal hypothermia because they have hardly any fat tissue, adipose tissue, hypoglycemia. They don't have enough stores, like no glycogen. And they also can have polycythemia and hypocalcemia, right? Congenital heart diseases that deteriorate with the closure of the ductus arteriosus include congenital heart diseases that deteriorate with the closure of the ductus arteriosus include Okay, so tetralogy of Fallot, critical pulmonary stenosis, juxtaductal coarctation of aorta, transposition of great arteries, total anomalous pulmonary venous drainage. Okay. Right, now this question, right? So we need to know a few things about the normal heart. This is like advanced, ordinary level science, right? So we know all this. Now, what we have to understand is, so this is aorta and this is pulmonary artery. In between this aorta and pulmonary artery, you have this structure called what? Ductus, isn't it? Ductus, right? We don't have ductus as adults because they disappear after a few days of life, right? But having a ductus will be very helpful in certain cardiac conditions. If the particular cardiac condition depends on the presence of the ductus, that is called duct-dependent circulation, right? They are dependent on the ductus, right? They are dependent on the ductus. Say you are dependent on your parents' funding, right? So if that is the case, like that. So if you do not have the ductus, you are going to die. So such circulations are known as what? Duct-dependent circulation, right? What does this magic ductus do? Now, this can do two things. Now, what is this? This is pulmonary artery, right? Or pulmonary trunk, rather. And this is aorta, right? There are situations where blood will go from pulmonary to aorta, right? What is the other name? Pulmonary circulation to systemic circulation, right? If you have inadequacy in systemic blood supply, right, there will be some conditions where systemic blood flow is not great. In those occasions, having a ductus will be handy because why? Pulmonary will send some blood to the aorta. Pulmonary will send some blood to the aorta and then say, okay, I know aorta, you are in difficult situation, economical crisis and all, we will help you, right? So if that is the case, okay, that the systemic circulation is dependent on the ductus. And there will be another situation where the pulmonary circulation is not that great, right? Pulmonary circulation is not that great. In those occasions, aorta will say, don't worry, you help me. Now this is my turn to help you, right? From aorta, blood will come to pulmonary thanks to the ductus, thanks to the ductus. Then what? That becomes a duct-dependent pulmonary circulation. Whether it is duct-dependent pulmonary or duct-dependent systemic, if having the ductus is helpful, such conditions are known as what? Duct-dependent circulations. Okay. So what is our first question? Is tetralogy of Fallot a duct-dependent circulation? Right. Is tetralogy of Fallot a duct-dependent circulation? So that's the question. Right. That's the question. Right. Okay. Now, before we discuss about dependent circulation, again, this is tetralogy of Fallot and this is the ductus. Right. This is the ductus. Right. We need to see if this ductus is going to be helpful in tetralogy of Fallot or not. If helpful, that becomes a true answer. If not, that is false. Right. Okay, now before we discuss about the ductus and its use, we need to know about tetralogy of Fallot. Right. I know out of many students here, many of you will know what tetralogy of Fallot, but there may be one or two few students who don't know what tetralogy of Fallot is. For them, I'm briefly going through what tetralogy of Fallot is. So what is tetralogy of Fallot? As name describes, when it comes to tetralogy, there should be four things, four abnormalities, right? What are those four abnormalities, right? So what are those four abnormalities? Now you see, this is the nice heart, right? This is the normal heart. In tetralogy of Fallot, one of the abnormalities that they have is a large VSD, right? They have a large VSD. So this is the number one problem, right? So they have a large VSD, right? I'm highlighting this word large for a reason. It's not a small VSD, but a large VSD, right? What else do they have? They also have overriding of the aorta. What does this mean? Overriding of the aorta, if I'm to stretch the aorta a little more, right, it will be somewhere here, right? Now, overriding of aorta means now you and me have aorta. That aorta goes into the left ventricle directly. Whereas in overriding of the aorta, what happens is aorta will be like facing towards the right ventricle as well, slightly. Right? So right ventricle also will open to aorta partially. Right? Right ventricle will also open to aorta partially. So this is what happens. Right? So when this happens, right ventricle has good dirty blood. Right ventricle has good dirty blood. This dirty blood will go to aorta or systemic circulation. That is one of the reasons why they get cyanosed. Right? That is one of the reasons why they get cyanosed. So one of the problems of tetralogy of Fallot is VSD large. Number two, overriding of the aorta. Right? Overriding of the aorta. Right? What happens next? When you have overriding of the aorta, now aorta is coming to the right ventricle. Aorta is coming to the right ventricle. Is that allowed? Is that ethical? It is like you are going to the neighbor's house, right? And you are trying to help them in a unnecessary way, right? Say you are helping, okay, so the neighbor has got a different family. You are asking, okay, do you need any help, right? So neighbor has got a separate husband. You are asking from the wife, do you need any help? Now what happens, right? What happens, it will be a disaster, isn't it? So when you try to help, the original person might constrict a little. This is what happens. When aorta comes and occupies the right side, the original structure, what is that? Pulmonary might have some congestion. So this causes pulmonary stenosis. Right? So overriding of aorta, and then there is pulmonary stenosis as well. When you have pulmonary stenosis, right ventricle is going to suffer, right? Because why? This becomes a right ventricular outflow obstruction, isn't it? Right ventricular outflow obstruction. Right ventricle will say, now see, aorta has come. It has compressed our pulmonary. So the pulmonary is narrow now. So we find it very difficult to send blood to the lungs. Then what will happen? Right ventricle will have to strain a lot to send blood to the lungs. So this causes right ventricular hypertrophy. If you see, right ventricle is bigger, thicker than left ventricle, right? Which should be the other way around in normal heart, isn't it? Right? So those are the four features. What are those four features? Large VSD, overriding of the aorta, right? Pulmonary stenosis, and right ventricular hypertrophy. Those are the four features. Now the question is this condition benefited by having a ductus? Any comments? What do you think? You can either comment here or shout. Will that be helpful? I can see a lot of yeses. Yes. Yeah, that's correct, right? Now, how will it help? Now, if you look at this one, you see, especially when you have severe pulmonary stenosis, you don't send enough blood to the lungs, right? This is when you get pulmonary oligemia anyway, right? So when you don't get enough blood to the lungs from right ventricle, lungs are going to suffer with hypoxia or reduced blood flow. Now in that occasion, if you have a ductus, aorta can send some blood, right? To the pulmonary circulation, right? What is dependent on ductus in this case? It is the pulmonary circulation, right? Pulmonary circulation is not getting enough blood due to pulmonary stenosis. If it is very severe, having a ductus will be beneficial, right? Having a ductus will be beneficial, right? If it is not very severe, whether you have a ductus or not is not going to make any difference, right? But in the exam, if they ask, tetralogy of Fallot is always duct dependent, false. It is not always duct dependent. If they ask, could be duct dependent. Yes, right. It could be duct dependent, right? When the question is like this, congenital heart diseases that deteriorate with closure of ductus arteriosus include, then you need to take this as correct, right? It doesn't ask whether it is always or common or anything like that. In that case, if this could deteriorate, then you have to take it as correct, right? Okay, right. And then, so that's correct. Critical pulmonary stenosis. This should be very easy now. Critical pulmonary stenosis. You see, this is the pulmonary valve. It's critically narrow, critically stenosed. When this is the case, is having a ductus beneficial? Is having a ductus beneficial? Any comments? Is that correct? Yes, obviously. When you do not send enough blood to the lungs, right? Lungs will not get enough circulation. In that occasion, having blood coming from the aorta will be helpful, right? So is critical pulmonary stenosis duct dependent? Yes, it is. Then juxtaductal coarctation of aorta, right? Juxtaductal coarctation of aorta, right? Okay, or else we can make it as preductal coarctation of aorta. Shall we put it in that way? Preductal coarctation of aorta, right? Preductal coarctation of aorta. Right. Okay. Now, what is preductal coarctation of aorta? Now, this is coarctation of aorta. This is, anybody can understand that there is a narrowing in the aorta. So it is coarctation of aorta. Right. What do you mean by preductal coarctation of aorta? This is the ductus. Right. This is the ductus. And the coarctation has happened before the ductal joining. Then it is called what? Preductal coarctation of the aorta. Very simple, isn't it? Preductal. The coarctation is before the ductus. Before the ductus. Right. Now, if this is the case, will having a ductus be beneficial? What do you think? Yes or not? Absolutely. Yes. So you see, aorta is sending blood this way. Right, aorta is sending blood this way, but at this point, there is an obstruction. It doesn't go beyond this point, right? So what will happen? Descending aorta is not going to get enough blood. Descending aorta is not going to get enough blood. Now, in this occasion, if you have a ductus, what will happen? Pulmonary can send some blood to the aorta, to the ductus. Right? Will that be beneficial? Yes. Right. So preductal coarctation of aorta, having a ductus is beneficial. Having a ductus is beneficial. Right. Whereas postductal coarctation of the aorta. Postductal, what does this mean? The coarctation has happened after the ductal opening. After the ductal opening. In this situation, will a ductus be beneficial? Will a ductus be beneficial? No. Why is that? Even if you send blood to the aorta, right, to the aorta, that again will get a blockage at this point. So that is not going to be helpful. Right? That is not going to be helpful. This is not going to be helpful due to two reasons. One reason is pretty obvious reason. Even if you send, right, it is like having a traffic, right? You take a shortcut. Again, there is a traffic here, right? So that's not going to improve your journey, right? So that is one reason. The other reason is what? The other reason is when you have coarctation, right? After the ductal opening, right? After the ductal opening, what happens? There is very high pressure here, isn't it? Very high pressure here. When you have very high pressure in aortic circulation, can pulmonary send blood towards the aorta? can't, right? You can't, because pulmonary circulation is low pressure, right? So it's very difficult for pulmonaries to send blood to the aorta if aortic pressure is high, right? When coarctation is here, aortic pressure will be very high. Whereas here, you see, right here, coarctation is here. This area, the pressure will be very high, but here pressure is low, isn't it? Because hardly any blood going, right? So in this occasion, pulmonary will be helpful, right? So pre-ductal coarctation. Pre-ductal coarctation is what? Before the ductus, right? Before the ductus. So here, before the ductus, coarctation has happened. Therefore, ductus is helpful. Ductus is helpful. Post-ductal coarctation, ductus is not going to be helpful, right? So in the exam, right? In the exam, when you see this kind of questions, we need to read the question very carefully. Number two, we need to draw diagrams on the paper itself and then make the decision, right? You don't have to just fail because we were in a hurry to make decisions, right? So repeating the exam might not be the best thing to happen, right? People can repeat, but if you repeated, in the repeat exam, you need to pass at least, right? So careless mistakes might take you a long way than we think, right? So we need to draw diagrams in these conditions and then take decision, right? So pre-ductal coarctation, if you put it in that way, right? Having the ductus is beneficial, yes. Transposition of great arteries. Transposition of great arteries, right? So what does this mean?
Hang on,
Transposition of great arteries, right?
Doctor, question.
Sorry?
Can you hear me? Doctor, sorry, I have a question. The question
Shall we
says...
discuss it after discussing 10 questions? Is that okay?
Yeah.
Right. We'll discuss after discussing 10 questions. We will have discussion. Or if it's a very short question, you can ask now. Then we can finish it off. Yes.
Yeah, the question says juxtaductal. It doesn't specify whether it's pre-ductal or post-ductal. So should we go just?
Yeah, that's why. That's why we need to change the question as you need to change the question as post-ductal. Right. Sorry. So this question, if you change it as coarctation is before the ductals, pre-ductal, then the answer is correct. Pre-ductal, right? We need to edit it as pre-ductal. And if you did not have any specific wording, whether it is pre-ductal or post-ductal, the examiner is asking whether coarctation of aorta is duct-dependent. Yes. If they ask, coarctation of aorta is always duct-dependent? No. Right? Always duct-dependent? No. So we need to, that's a very good question. We need to read the question very carefully, right? Rather than jumping into decisions. Right. Okay. Transposition of great arteries. Right. So transposition of great arteries. So what is this? We know what are the great arteries? There are two great arteries. Those are pulmonary and aortic. We know aorta starts from the left ventricle, right? Aorta starts from the left ventricle. Pulmonary starts from the right ventricle, right? Pulmonary starts from the right ventricle. If this happens the other way around, right? If this happens the other way around. Now, if you look at this one, you see aorta starts from the right side, which is quite unusual, right? Aorta starts from the right side. Pulmonary starts from the left side. Exactly opposite of how it should happen, right? So when aorta starts from the right side, all the dirty blood will go to the systemic circulation. When you have dirty, deoxygenated blood in systemic circulation, child will be cyanosed. This is why transposition of great arteries cause cyanosis. Right. This is why transposition of great arteries cause cyanosis. I hope you know that transposition of great arteries cause cyanosis. Anyone who doesn't know that? There may be a few who don't know. That's okay, because this is not the exam, right? But if you can remember, there are a couple of cyanotic heart diseases. They all start from letter T. They all start from letter T. There are at least 5 such cyanotic conditions which start from letter T. What are those? Number 1, we can write tetralogy of Fallot. Right, tetralogy of Fallot. Second T, this one, transposition of great arteries. Then the third T, total anomalous pulmonary venous drainage. Total anomalous pulmonary venous drainage. Fourth T, tricuspid atresia. Tricuspid atresia. Fifth T is truncus arteriosus. Truncus arteriosus. Right. Okay. Right. So out of those 5 T's, this is one of them. So transposition of great arteries is a cyanotic heart disease. Now, if you do not have a ductus, will this architecture be compatible with life? No. Right? Baby is going to immediately die. Because why? You can't survive without oxygen to the brain. Right? Babies will survive in utero because thanks to mother would send good blood to the baby through placenta. Once you cut the umbilical cord, you become an independent person, right? Then after that, if you do not have oxygen, you are going to die. Now, if you look at this one here, it's the brain, right? Brain is not going to get a drop of oxygen if you are sending blood from the right side. The child is going to die. If he is not going to die, you need to send some blood, good blood into the aorta, some good blood into the aorta, oxygenated blood into the aorta, right? So that can happen if you have multiple different kinds of anastomosis. One of them could be what? Ductus. If you have ductus, you can send good blood or oxygenated blood into the aorta. That will be life-saving, right? That will be life-saving. So transposition of great arteries is duct-dependent? Yes, it is, right? It is duct-dependent. So that is correct. Right. Then total anomalous pulmonary venous drainage. Total anomalous pulmonary venous drainage. Now what happens there? Right. Can you figure out what this cartoon is? Is it too complicated? Right. So total anomalous pulmonary venous drainage. So what happens is, so this is right ventricle. Right ventricle will send blood to the pulmonary arteries. Pulmonary arteries will bring blood to the lungs. In lungs, what happens? Blood will be oxygenated. Blood will be oxygenated. This is what happens. This oxygenated blood through pulmonary veins should come to the left ventricle. Left atrium. Should come to the left atrium, isn't it? This is what happens in you and me. Right? This is what happens in you and me. But in total anomalous pulmonary venous drainage, what happens is oxygenated blood will go back to the right side. Right? So see, this oxygenated red blood goes to the right side and join superior vena cava and empty into the right side again. This looks crazy, right? You send blood from the right side because it is dirty to purify, and you send or you clear that blood in the lung and then sending that back into the dirty chamber. So this is going to be a never-ending story. You clean and send them to dirty. Clean and send them to dirty. So this is called total anomalous pulmonary venous drainage. Right? Total anomalous pulmonary venous drainage. So then what happens? Is you are not going to get blood into the aorta. Right? are not going to get blood into the aorta, right? So this is what happens. So what? So this is aorta, right? So this is aorta. Aorta is not going to get good blood, right? Aorta is not going to get good blood, right? So in this situation, could having a ductus be beneficial? Could that be beneficial? Yes or no? Where do you have good blood? Now you have at least comparatively good blood in the right side. Why is that? All the purified blood came to right side, isn't it? All the purified blood came to right side, right? So aorta is not going to get, or left side is not going to get enough blood, right? Left side is not going to get enough blood, right? And then you have this pulmonary circulation, pulmonary arteries, right? Pulmonary arteries are there, right? So in pulmonary arteries, do you have at least some oxygenated blood? Yes. Why is that? Say you got some oxygenated blood from the lungs to the right side, isn't it? From lungs to the right side. See, lungs send blood to the right side. Then what happens? Pulmonary will have some oxygenated blood, right? If you send at least some amount of that blood to the aorta, will that be helpful? That could be helpful, right? That could be helpful until you do the permanent correction, right? Until you do the permanent correction or the complete correction. You name different surgeries are there. So one of those surgeries, if you can do, then the child will survive. But until that, having a ductus could be beneficial. This is not going to be very beneficial because in this condition, you don't have very well oxygenated blood in any of those tubes. Did we understand the point? Right. Even pulmonary doesn't have very well oxygenated blood, but something is better than nothing. Right. Therefore, having a ductus could be beneficial. So what is the importance of knowing this to us as doctors? If a certain condition is benefited by having a ductus, right? Keeping the ductus open will be life-saving, right? Keeping the ductus open will be life-saving. Suppose you are working in a peripheral hospital, right? You are working as a house officer in a peripheral hospital where you don't have a pediatric cardiologist, right? We don't have pediatric cardiologists right across the country. In which hospitals do we have pediatric cardiologists? If that comes as a MCQ, right? So which hospitals have pediatric cardiologists? Yeah, Ledridge Hospital, we have several pediatric cardiologists. And then Karapitia, we have pediatric cardiologists. Anuradhapura, we have pediatric cardiologists. Jaffna, right? Most of the other centers, we don't have pediatric cardiologists, right? Suppose you are working in some other hospital, say Kilinochi Hospital, right? Kilinochi Hospital, nearest hospital where you have a cardiologist would be Jaffna. Now this child is getting cyanosed, right? Desaturating. Jaffna pediatric cardiologist says, send the baby to Jaffna, which will take 1 hour from ambulance. Oh, he is on leave. So they ask you to send the baby to, say, Kandy or Ledridge Hospital or Sirimau Bandaranaike Hospital, Peradeniya, right? This will take at least few hours. So during these few hours, if the baby keeps on having very low saturations, that might not be good for their brain. So if you are to send certain amount of at least oxygenated blood, what should you do? You need to keep the ductus open. How do you keep the ductus open? By giving this medication called what? Prostaglandin. Prostaglandin. So having prostaglandin will be life-saving. You start prostaglandin, right? Prostaglandin has got enough and more complications. One of the complications is that can cause apnea. That can cause apnea. Baby might stop breathing. Now the double trouble, right? They had heart problem. Now the breathing also is problematic, all right? Some babies can stop breathing. So you can't start prostaglandin and send the baby in an ambulance and you stay in the quarters. That can't happen. You need to go. When I say you, who should you be, right? Somebody who can intubate, right? If you can't intubate, going in that ambulance might not be very helpful, right? Because why? If the baby doesn't breathe, either you need to intubate or start bag and mask ventilation, one of those, right? One of those should be done, otherwise baby is going to die, right? Now, you start prostaglandin and send the baby to cardiology unit, nearest cardiology unit available, and then cardiologist will do the surgery, right? Then the baby will survive cardiologist or cardiothoracic surgeon, right? If you do not know whether it is a duct-dependent circulation or not, say you are working in Cyanotic hospital, say you don't have echo facilities. You have echo facilities in Cyanotic, that's a different story. But if you do not have, right? Now what can you do? Baby is getting cyanosed. Say day 3. Day 3 or day 2, day 3 is the time when the ductus will naturally close. That is when babies will get cyanosed. That is when babies will get cyanosed. Now what can you do? You don't have echo facilities. You don't know whether it is a duct-dependent circulation or not. Then what? Then you can start prostaglandin, assuming that this is duct-dependent. Right? Assuming that this is duct-dependent. So that way you can save the baby. Right? That way you can save the baby. Right? Baby will say the two possibilities is baby will survive. Then everybody will thank you, Facebook post, this doctor is a god, this and that. The baby died because you started prostaglandin and baby became apneic and died. Will that be a problem? No, because you have done the best possible care for the baby with available facilities. Right, with available facilities. So you thought that this could be duct dependent, you started. Right. Having apnea after starting prostaglandin is very well known. Right, you knew that. Right. But in the other scenario, baby died because you did not start prostaglandin because you don't have echo facilities. Now that is not acceptable, right? That is not acceptable. You can't say we don't have echo, so I did not start. That might not be the best thing. If you have a doubt, our cardiologists are very kind and very approachable. You can always call and ask, right? We have this situation where the baby on day 3 is getting cyanosed, desaturated. We think that it is a duct-dependent circulation, but we don't have echo facilities at the moment. Are you happy for us to start prostaglandin? Then the cardiologist will say, yes, go ahead. Or they will say, no, don't. Right? Usually they will not say, no, don't. They will say, yes, go ahead. Then you are covered. Now, the cardiologist has that authority or the expert opinion to give. Okay, you give that. Then you are covered. Right? You haven't started it as a general pediatrician or a pediatric house officer. House officers will not make these kind of decisions anyway, right? But at least we need to suggest, right? So if this baby was delivered or if this baby was deteriorated, right, in one of your night shifts as a house officer, right? What are the few things that we can do? You can panic. You don't know what is happening, right? You don't know what is happening and you panic, and the more you panic, the other people around you will start stressing you, right? Say nurses, attendants, parents, they all will press you when they understood that you are not a confident doctor. So don't panic. You can call your consultant and say, now this baby is desaturating, sir or madam, what can I do? That is something. If you think that I'm blank, thought block, or if you are a smarter house officer, you can say, this baby on day 3 started deteriorating, is getting cyanosed. I think that it's a duct-dependent circulation. Now that the ductus is closing, sir, is that okay if I arrange prostaglandin? No, you are not just reporting, you are giving your opinion as well. This is what is expected, right? This is what is expected. Then they will say, yes, you start. Oh, no, don't start. Whole cardiologist and take their opinion as well, right? So that is how you tackle this kind of scenarios in real life, right? Okay, so that question took a long time because we had to discuss 5 pediatric cardiology conditions, right? So when this is the case in the exam also, take time. right? So you have, say, 120 minutes to do, I'm just telling, say 1 hour to do 30 questions. This doesn't mean that you have to take 2 minutes for each question. No, there may be some questions where you can do within 1 minute, right? Whereas other questions might take 5 minutes. That is your 2 hours. You can spend that the way you want, right? So if you look at this question, see, fairly straightforward. Fairly straightforward. If you know, you know. If you don't know, you don't know. There's no logic, right? Regarding peak expiratory flow meter, I don't know whether you have seen this gadget before, right? Peak expiratory flow meter. So this is peak flow meter, right? So this question is based on this gadget, right? Interpreted with the height of the child. Say what you do is you ask child to take a good deep breath in, right? And then you ask child to keep the peak flow meter very, very tightened to the mouth and exhale as forcefully as fast as possible. Then what will happen? With the force of the air column, exhaling air column, what will happen? This plastic piece will start moving this way. Depending on the distance of movement, the spirometer will tell you what was his peak expiratory flow rate. Right, peak expiratory flow rate. Right. Say this child's peak expiratory flow was 300. I'm just telling random values. How do you know if it is normal or abnormal? How do you know if it is normal or abnormal? Yes, how do you decide? Now there are nomograms or normal value charts. Right. Someone to decide whether it is normal or not, what do you have to consider? Few things. Number one, child's age. Age, right? We need to know the age because the normal values are age dependent. The child's sex, male or female, and the height. Age, sex, and height. Age, sex, and height. Depending on the child's age, sex, and height, you see whether the child's peak expiratory flow rate value is normal for their age, sex, and height. If normal, it's normal. If it is not normal, there could be a pathology, right? There could be a pathology, right? So that is about peak expiratory flow, right? Now suppose this child had a peak expiratory flow of 300, right? So it was 300. So are you going to take this value for comparison? Or do you ask child to do this test for a couple of more times? You ask child to do this for 3 times, right? 3 times. Say first time it is 300, next time it is 400, and the last time it is, say, 500. I'm just telling random values. 300, 400, and 500. Which value are you going to take? Which value are you going to take for plotting? Anyone? 300?
The highest
400?
one.
Highest one. It is the highest one that you take, not the average or anything like that. You take the highest one, right? You take the highest one, right? Okay, so regarding peak expiratory flowmetry, interpreted with the height of the child is correct. Effectively used in preschool children. Is that correct? Can you use this to check their lung functions when they are in preschool? No. Child has to understand this properly. So this is not effective when they are less than 5 years in general. Right? So preschool, no. Used for home-based assessment of asthma control. Can this be used at home? Yes. Home, bedside, yes. Average of 3 readings is taken? No. It's the highest value you take. Best assessed in standing position. Is that correct? Best assessed in standing position. Is that correct? Yes. Right. It is not seated position, but standing position. So interpreted with the height is true. Effectively used for preschool is wrong. Used home-based asthma control, yes. Average reading is taken, no, it's the highest that you take. And then best assessed in standing position is correct. Right. Regarding childhood absent seizures. Affected children experience seizures several times a day. Seizures last less than 1 minute. Seizures respond to carbamazepine. Good long-term prognosis. Last option we can change. Could be associated with myoclonic seizures. Could be associated with myoclonic seizures. Yeah. Is right. Right. So what do we know about absent seizures? Now, absent seizure is a type of epilepsy. We know what epilepsy is. What is the definition of epilepsy? It's a condition where the child gets recurrent, unprovoked seizures. Recurrent, unprovoked seizures. You should have recurrent seizures, so at least 2 times. And they should be unprovoked. There should not be a provocating factor like hypoglycemia, head trauma. When you have those, the children will anyway start seizing. But if the child starts to have fits without any provocation, then it becomes a recurrent, unprovoked seizure. If you have multiple of those, then it is called epilepsy. Right? Then it is called epilepsy. Right? So, right. Okay. So recurrent, unprovoked seizures is known as epilepsy. Right. Now, what are the different types of epilepsy that we know of? There is one type called what? Generalized tonic-clonic seizures. Generalized tonic-clonic seizures. What do you mean by generalized? Both sides are involved, left and right. Tonic, the tone is increased. Clonic, there is these jerky movements. Right? If you have the both, that becomes tonic-clonic. Tonic-clonic. Right? Parents will say, Babage anger daradadu vela. Daradadu una kiyanne tone increased. Gahinda patan gatta. Clonic. Right? So that is tonic-clonic. Both sides, then it becomes generalized tonic-clonic. Whereas some children can have focal tonic-clonic, only one side. Right? So different types of seizures. The other type of seizure is what? Absent seizures, where you don't see jerky movements, but child will start to have staring episodes like this. Couple of seconds, like daydreaming, they will stare at you or whoever. During that 10 seconds or so, even if you talk to child, they will not respond to you. Right? So that is called absent seizures. Absent seizures. How do you differentiate this from daydreaming? Daydreaming happens in particular environments, right? Especially when the things are boring, in a Zoom session or something like this, right? But absent seizures, it could happen at any occasion while watching the favorite movie. Child starts to have absent seizures. That could happen day and night both, right? There's no specific time or place for these to happen, right? So absent seizures, when that happens, they usually last for few seconds only, right? Seizures last less than 1 minute is correct. Seizures respond to carbamazepine. Now this is wrong. So we need to know different types of seizures and their anti-epileptic of choice. Anti-epileptic of choice. Absent seizures, we give things like valproate, ethosuximide, right? We can give valproate, we can give ethosuximide, but carbamazepine is not particularly given. In fact, carbamazepine can make absent seizures worse, right? This can make absent seizures worse. We don't give them, right? What are the medications that we can give? We can give ethosuximide. We also can give valproate. Right? Good long-term prognosis. Children with absence seizures, do they have good long-term prognosis? Yes. Right. Now, compared to some other different types of seizures, absence seizures are the best ones to have if you are to have one. Prognosis is good, right? As could be associated with myoclonic seizures, yes. Could be associated with myoclonic seizures is correct, right? Right, so these are absence seizures. You get something called 3 per second spikes and waves. Every 1 second, you get 3 spikes. This is called absence seizure EEG pattern, right? 3 per second spikes and waves, right? And then seizure management, this is what I was talking about. Generalized tonic-clonic seizures, we used to give valproate. Generally, valproate is very useful, right? Focal seizures, we usually go by carbamazepine. Carbamazepine is one of the best drugs to give, right? Carbamazepine is one of the best drugs to give. Then absence seizures, we give sodium valproate and ethosuximide. Sodium valproate and ethosuximide, right? Whereas myoclonic seizures, we give valproate, and there is another comparatively new anti-epileptic called levetiracetam. Right. Okay. Right. Okay. Right. Okay. There is this request whether you can have the presentation, right? The presentation that I'm doing, I can post that in the Telegram group. I'm going to post the Telegram group link, Uda, so you can join this Telegram group now, right? Because I have multiple WhatsApp groups, because one WhatsApp group can only accommodate 1,000 students, which is not sufficient. So Telegram, of course, we can accommodate up to 200,000 students, right? So if you join this, you will get all the documents or educational materials that I use in this common Telegram group, right? Okay, right. So I will upload the presentation as well once we finish the session today. Right, okay. Regarding hematuria in children, right? Regarding hematuria in children, you know hematuria, so the passage of red cells in urine is hematuria, right? So regarding hematuria in children, defined as more than 5 red cells in uncentrifuged sample, right? Uncentrifuged sample. Suppose you get, I'm sure you must have got all these by now, say, you know, that you are a medical student, and then especially if you are like 3rd year, 4th year, final year medical student, your non-medical friends will used to think that you are a doctor, you are a pediatrician, you are a professor, right? In their eye, right? Suppose one of your engineering friends is sending a urine report of their mother, their father, right? It shows red cells of 3, right? Red cells of 3, right? There are 3 red cells in their urine, and then they are very worried, right? There are 3 red cells in their urine sample, mothers or their child. Is that normal? Is that normal? And on the same urine report, there are 8 pus cells as well, right? 3 red cells, right? 8 pus cells, right? They WhatsApp the report to you because you are their family doctor. You need to reply them back whether it is normal or abnormal. Their question is, does this need any treatment? What do you think? Now, red cells, the normal number is up to 5. Anything more than 5 is abnormal. Anything more than 5 is abnormal, Pus cells, what is the cutoff? 10. Pus cells cutoff is 10. Red cells cutoff is 5. Right? So hematuria defined as red cells more than 5 is that correct? Yes. It's of glomerular origin if RBC casts are present. Right? We can change the question slightly. Is likely to be glomerular in origin if red cell casts are present. Right? If there are red cell casts, does that mean that these red cells are coming from the glomerulus? Yes. If the red cells are coming right from glomerulus, right, when they filter through glomeruli, and then subsequently when they travel across the tubuli, what will happen? The red cells, the shape will change. Then you get some crescent shape or casts, red cell casts. If you have red cell cast in general, the bleeding is of upper renal tract, right? Likely glomerular. So glomerular nephritis, you get red cells and red cell cast. So this is correct. High protein to creatinine ratio can be seen in hematuria. What do you think? What do you think? Any comments? Any comments? Yeah. High protein to creatinine ratio can be seen. What do we think? Any comments? What do you mean by high protein to creatinine ratio? Right? So urinary creatinine level will be normal unless the child has renal failure. Right? But if you are producing more protein in urine, what will happen? Protein, creatinine ratio will go up, right? Because you are producing more protein in urine. Simple. So in proteinuria, forget about hematuria. In proteinuria, do you get high protein creatinine ratio? Yes, right? Obviously. Now the question is not that. Do you get high protein creatinine ratio in hematuria? Is that correct? Is that correct? Answer, yes. Again, yes. Why is that? Simply because red cells have proteins. Red cells have protein. Red cell membrane has got protein. So that when you have more red cells in urine, there is a higher chance for that urine to have more protein as well. Right? More protein as well. Right? So in hematuria, is it likely for children to have proteinuria as well? Yes. That is not because they are losing protein as well. This could be the case in some occasions. But more than that, red cells themselves have protein. So those protein will be detected as proteinuria. Right? Then when you have normal creatinine and high protein in urine, protein creatinine ratio will go up. That is simple maths. Right? High protein to creatinine ratio can be seen? Yes. Right. Then the next question, we need again slight modification. Could be intermittent in post-streptococcal glomerulonephritis? Yes. It could be intermittent. Some days they might not have proteinuria depending on how much the inflammation is. Some days they might have. Considered as benign when it is painless. You have hematuria, but the child doesn't have any pain. Does this mean that it is benign? Obviously no. Right? Some children can have renal cell carcinoma, also known as Wilms tumor. It's a cancer. What else can you have? Right? But they have painless hematuria. Right? Or they can have serious clotting disorder. Painless. Right? But painless hematuria doesn't mean that the condition is benign. Right? So painless considered as benign when it is painless, wrong. So defined as more than 5 red cells abnormal, yes. Glomerular RBC cast, again, yes. High protein to creatinine ratio can be seen, yes. Could be intermittent in PSGN, yes. Considered as benign when painless, No. Right. Okay. I have briefly gone through some of the, I told you during last time also, Kudavat, this PDFs or the reviews made by students for their juniors, which are freely circulated among you, which is good to have, but you need to read them very carefully, right? You need to read them very carefully because some of the answers are wrong, right? At least 20 to 30% of the answers given in those review books written by students are wrong. That is not their problem. They are writing books with their capacity, with their experience, right? Especially when it comes to SBS, they probably have zero experience in managing real patients, right? And they have not got exposure to healthcare system as professionals, but you must have got some exposure as medical students. But that probably is not good enough, right, to make decisions when it comes to single best answer, even true false. I have seen one of these reviews were mentioning high protein creatinine ratio can be seen was taken as wrong, and the explanation was in proteinuria this could be high, but hematuria it is normal. No, that is not as simple, right? Again, I'm telling, we all respect for their effort because they passed the exam, right, without thinking about their straightforward future after passing exam. They could have thought of doing postgraduate exams, lab, AMC, USMLE. Instead of doing them, they decided to make these books for juniors to refer, which will not be beneficial for them at all. But while doing that, they can do mistakes, because when we do MCQ books, MCQ reviews, so when I do that, I do multiple reviews. I ask somebody else to review, probably a person better than me, a professor, right? He asked, professor, could you please, sir or madam, could you please review this and tell me what the deficiencies are, right? And then I send the beta version to students. Beta version means limited number of students will be doing these questions, and I asked them, what do you think? Are the questions very clear? So it is a multiple process. Understandably, your seniors can't do that kind of multiple processes because it's voluntary work, right? So when you read those questions, be very, very careful. You can read, but cautiously, right? Regarding normal growth during infancy. Normal growth during infancy. Right. Birth weight doubles by 8 months. Birth weight doubles by 8 months. Is that correct? Birth weight doubles by 8 months. Any comments? Is that correct? No, birth weight doubles by 5 months. Right, 8 months is too late. Right. Then what happened to birth weight? Birth weight triples by 1 year. Birth weight triples by 1 year. Right? Then birth weight quadruples by 4 years. Sorry, 2 years. Right? Doubles by 5 months. Triples by 1 year. Triples by 2 years. Right? That is what happens. So birth weight doubles by 8 months is wrong. Right? Head circumference increases by 2 centimeters during first 3 months. Is that correct? Right. Now, what is normal head circumference of a term baby? Term baby, normal head circumference is 35 centimeters. 35 centimeters is normal head circumference. right? And then what happened to this 35 centimeters? During first 3 months, head circumference increases by 2 centimeters per month, right? 2 centimeters per month, right? Second 3 months, 1 centimeter per month. 1 centimeter per month, right? So now what? Now 6 months gone. Then remaining 6 months, it will increase by 1 centimeter per month. Sorry, 0.5 centimeter per month, right? I will repeat. First 3 months, 2 centimeter per month. Next 3 months, 1 centimeter per month. Next 6 months, 0.5 centimeter per month, right? So that is what happens. So head circumference increases by 2 centimeter per month is correct. Average length at birth is 45 centimeters. Wrong. It is 50. 45 is always, 45 is small. Right? Birth, upper segment to lower segment ratio is 1.7:1. Is that correct? At birth, upper segment is 1.7, lower segment is 1. Is that correct? Yes. At birth, upper segment is bigger. This is due to comparatively large head. Right. Okay. At birth, upper segment to lower segment ratio is 1.7:1 is correct. Growth hormone is the main determinant of linear growth during infancy. What do we think? Growth hormone is the main determinant of linear growth in infancy. Yes? Yes, is that correct? No, it is not. Right? It is not. It has got multiple factors, especially the nutrition will play a major role in growth in infancy. Right? After that, growth hormone will play a major role as well. So the answer is birth weight doubles by 8 months is wrong. Right? It is not 8 months. Birth weight doubles by 5 months. Right? 5 months. So that is false. Right? Hip circumference increases by 2 centimeters during first 3 months is correct. Average length at birth is 45 centimeters. No, it is 50. At birth, upper segment to lower segment ratio is 1.7:1 is correct. Growth hormone is the main determinant of linear growth during infancy is wrong. Right. Right. So I have this question. When we're practicing MCQs, how do we find the answers? What are the best references to use? Currently, we are using Illustrated Pediatrics, textbook of Pediatrics, and national guidelines. Okay, a good question. Now, single best answer, by reading books itself or by reading books only, it's very difficult to find out or approach to the best, what is the best answer, right? So that is difficult. The textbooks will give facts, but how to apply those comes with experience, and either you have to get that experience or somebody experienced will have to say. So in your case, it will be your lecturers, right? So that is what, because no textbook will say if this is the scenario, this is the best answer. If this is the scenario, this is the best answer, right? Then like facts, right? say in single best answer, you get a scenario like this. 5 months old baby presents with a maternal concern of poor weight gain. His birth weight was 3 kilos and current weight is 6 kilos, right? What is that? Current weight is 6 kilos, birth weight is 3 kilos, and he is now 5 months. So 5 months, what has happened? Birth weight has doubled, isn't it? Birth weight has doubled, right? Then there will be few answers. One of the answers will be reassure and send home, right? Reassure and send home, right? So to decide, yes, this is reassure and send home, one has to know when birth rate doubles, right? So to get that information learned, either you can use the lecture notes from your lecturers because they all are well qualified, or standard textbooks. So one of the textbooks will be Illustrated Pediatrics of Medicine, written by Tom Leisha. It's a nice book, but things might not be 100% relevant to other countries than United Kingdom, because that book was written according to United Kingdom guidelines, right? And if you need some advanced learning, like last week, I have posted a couple of questions from Metabolic Pediatrics. Illustrated might not be good enough for that, right? For selective reading, if you ask what the best book is, I would say Nelson Textbook of Pediatrics. That again is very big book. Unless you read the selective, that area only, if somebody decides to read cover to cover, you might not be able to do anything else during your 5 year of medical school than reading Nelson. Because that book is that big, that can be taken as a reference book, right? So we haven't read it cover to cover, right? I have passed MBBS, DCH, MD, Pediatrics, MRCP, CH, you name most of these exams, local and international. But I have never read Nelson cover to cover. You don't have to, right? You can't do that either, right? But that's one of the good books, right? And then international sort of articles, you use some reputed journals like Up to Date, New England Journal. Several articles are there, right? Yeah. But for your purposes, Illustrated and then some other lateral thinking will be very helpful, right? Okay. Yeah, the anthropometric measurements, length at birth is, so this is what we discussed. Head circumference at birth, it will be 35. First 3 months, 2 centimeters per month. Next 3 months, 1 centimeter per month. After that, next 6 months, 0.5 centimeter per month. So if somebody asks, what is the total head circumference gain during first year of life? It will be 6 plus 3 plus 3, 12. Right, 12. Right, there will be 12 centimeter gain. And the weight, anything more than 2.5 is considered as normal for most of the developing countries, right? What happens to that weight? During first week or up to 10 days of life, birth weight will reduce by up to 10%, which is normal because the babies are losing extra water, right? Babies are losing extra water. After that, what happens? They will start to gain weight. Birth weight will double by 5 months, triple by 1 year, quadruple by 2 years, right? So that's about the weight gain. And then the length gain, right? Length gain. First year, the length increased by 25 centimeters, right? First year, length will increase by 25 centimeters. If the birth length was 50, at your first birthday, you will be 75 centimeters long, right? You will be 75 centimeters long. Second year, another 12.5 centimeters, another 12.5 centimeters. Then third year, the length gain might not be very impressive. Again, you will get a peak of growth during puberty, right? Pubertal age, you might get like another around 8 to 10 centimeters per year growth, right? 8 to 10 centimeters per year growth, right? Okay, right. Okay, so that's about anthropometric measurements, right? Through that, we have not discussed a lot of questions, but in one question, we are discussing things which will be sufficient for another 5 questions for us to do. Regarding management of gastrointestinal conditions, acute gastroenteritis is treated with oral zinc. Again, we can change this question a little. Acute gastroenteritis could be benefited by zinc treatment. Could be benefited by zinc treatment. Yeah. So what do we think? Will that be beneficial? Yes. Acute gastroenteritis, right? If you give zinc, the severity of acute gastroenteritis current episode will be less. Zinc supplement. Also, giving zinc will be beneficial to prevent gastroenteritis at least for next 3 months. Right? At least for next 3 months. Right. If you have zinc deficiency, on top of that diarrhea, you will get a condition where you get severe perioral and perianal excoriation. Right? Around the anus, there will be excoriation. Around the mouth, there will be excoriation. That condition is known as acrodermatitis enteropathica. Right? Acrodermatitis enteropathica. So you can prevent all those by giving zinc. Right? Polyethylene glycol is useful in management of constipation. Yes. Right? So this is one of the laxatives. Ulcer disease is treated with magnesium hydroxide. Yes, we give magnesium hydroxide and aluminum hydroxide mixture. That will be helpful to reduce or to neutralize the acidity. Thickening of feeds is effective in management of gastroesophageal reflux disease. Is that correct? Yes, the babies will be more refluxy. Food will come back from stomach to esophagus if they are liquid, right? If they are thick, like the principle of gravity, chance of refluxing it back to the esophagus will be less. For that, we can give milk thickeners if they are on milk. If not, you can give solid food than liquid food. Mesalazine is used in management of ulcerative colitis. Yes, we give that for children with inflammatory bowel disease, right? Inflammatory bowel disease. So this is polyethylene glycol, which is a powder, and then mesalazine would come in like tablets, right? So acute gastroenteritis treated with zinc is correct. Polyethylene glycol is useful in management of constipation, correct. Peptic ulcer is treated with MAC sulfate, correct. Thickening of food is beneficial in GORD, correct. Mesalazine is used to treat ulcerative colitis, correct. Right. Hemostasis. Platelets form the primary hemostatic plug. Is that correct? The primary hemostatic plug formation and then hence stopping the initial bleeding is by platelets. Is that correct? Yes. Bleeding time is prolonged in platelet function disorders. Is that correct? When you do not have enough platelets, or you have platelets but their function is not great, either of those, what happens? Bleeding time will be prolonged. Right? Bleeding time will be prolonged in platelet problems. Whereas clotting factor disorders can cause prolongation of clotting time. Right? Liver produces the most coagulation factors. Yes, especially vitamin K dependent coagulation factors. Prothrombin time is prolonged in hemophilia. Yes. Any comments? Prothrombin time is prolonged in hemophilia. Is that correct? No. No. In hemophilia, APTT is prolonged. APTT is prolonged. Protein C deficiency increases the chance of thrombosis. Is that correct? Yes. Protein C and protein S deficiency. Right. When you do not have enough protein C and enough protein S, that causes prolongation, that causes more and more thrombosis. They will present with strokes. Right? They will present with stroke. Childhood strokes are very rare, but if they have, we need to think, could that be protein C deficiency or protein S deficiency? Right. Slightly more short note for us regarding these clotting studies, right? Bleeding time, platelet problems, we can write what happens. Platelet problems, you get prolongation of bleeding time. Platelet problems, bleeding time prolonged, right? Clotting factor problems, clotting time prolonged, right? Clotting time prolonged, right? Then hemophilia, APTT is prolonged. Right. Liver failure and vitamin K deficiency, INR is prolonged. INR is prolonged. And I'm sure you must have heard of this condition called what? In which condition you get prolongation of bleeding time and clotting time both? Von Willebrand disease. Von Willebrand disease, bleeding time and clotting time both are prolonged. Right? Bleeding time and clotting time both are prolonged. In which condition do you get prolongation of bleeding time, clotting time, APTT, INR, everything? Yeah? DIC, disseminated intravascular coagulation. Everything is prolonged. Right. Okay. So the answers for this question, platelet forms primary hemostatic plug is correct. Bleeding time is prolonged in platelet disorders, correct. Liver produces most of the coagulation factors, correct. PT is prolonged in hemophilia is wrong. Protein C deficiency causes thrombosis, correct. Nutritional, regarding nutritional properties of breast milk. Regarding nutritional properties of breast milk. Right. It's relatively low in vitamin K. It's rich in polyunsaturated fatty acid. Bioavailability of iron is high. Hind milk is richer in fat than fore milk. Has a higher amount of whey protein compared to casein. Right. So what do we have to know? Breast milk, cow's milk, and formula milk comparison is like an essential part of any pediatrics paper. It's very difficult to have a pediatric paper without this concept of breast milk. It is that important. Right. So it is relatively low in vitamin K. What do we think? Is that correct? Any comments? Breast milk doesn't have enough vitamin K. Is that correct? Yeah, it is. It is correct, right? Breast milk doesn't have enough vitamin K is correct. Does mother send enough vitamin K during pregnancy to the baby? Again, no. Right? So baby doesn't have, baby doesn't have enough vitamin K at birth. Even if you breastfeed, you are not going to get enough vitamin K. Therefore, what can happen to the baby? Baby can die with vitamin K deficiency bleeding. That is called hemorrhagic disease of newborn. Hemorrhagic disease of newborn. Right. How do you prevent? By giving vitamin K IM injection at birth to every baby. This is what we do. If mother's milk had enough vitamin K, we wouldn't have given vitamin K to every baby. Does that make sense? Right? So mother's milk is the best, but it has got its own limitations. One of those is vitamin K. It's rich in polyunsaturated fatty acids. Yes. So this is claimed to be beneficial for brain development. Bioavailability of iron is high. Yes. Again, breast milk is not a good source of iron. But whatever available iron in breast milk has got higher bioavailability. Right? Bioavailability is high. They will be absorbed better. Hind milk is richer in fat than fore milk. Is that correct? When the baby starts to suck milk, the initial bit is traditionally known as fore milk. The last bit that he is going to suck in is hind milk. Which milk has got high amount of fat? That is hind milk. Right? Initial milk or fore milk has got more sugar, more carbohydrate. That is sugary. That is how the baby is attracted to breast milk. Then he will keep on drinking fat as well at the end. Right? So hind milk has higher, richer amount of fats, yes. Has higher amount of whey protein compared to casein. Is that correct? Breast milk has got higher amount of whey protein, yes. Breast milk has got higher amount of whey protein. Cow's milk has got casein. Cow, casein. C and C. Cow, casein. Mother's milk, whey protein. Right. So the answers are, it's relatively low in vitamin K is correct. Rich in polyunsaturated fatty acid, correct. Bioavailability of iron is high, yes. Hind milk is richer in fat than fore milk, that is correct. Has higher amount of whey protein, that is also correct. Right. So you see breast milk, cow's milk and formula milk comparison, right? Breast milk, cow's milk and formula milk comparison, right? See, so all these fatty acids are high, right, in breast milk, right? Fatty acids are high in breast milk. And then you see protein, breast milk, we consider that it has right amount. Cow's milk, too much of protein. Formula milk companies will reduce cow's milk to the desired amount. Right. And then you see breast milk has got high amount of lactose. That is why breast milk is more sugary or sugar tasty than cow's milk. Vitamin and minerals, adequate if mother has enough vitamin, but vitamin K and D is not sufficient. Right. So there's this chart in any standard textbook. It's a good idea to go through that. Right. Recognize complications of mycoplasma infection. Recognize complications of mycoplasma infection. Acute from glomerular nephritis. Is that correct? Mycoplasma. What is that? It's an atypical bacterial infection, isn't it? It's an atypical bacterial infection. Right? And then it causes multi-system involvement. The commonest is chest infection. The commonest is mycoplasma, chest infection, mycoplasma pneumonia. Right? You suspect mycoplasma pneumonia. Mycoplasma pneumonia, what happens is the child will cough a lot. When you examine, hardly any lung signs. Child looks well, walking around, no much of oxygen need. But when you do the chest x-ray, it looks disastrous, right? If you see disproportionately bad chest x-ray appearance compared to the clinical picture, we need to think mycoplasma infection, right? So that is when it comes to chest, right? Can it cause glomerulonephritis? Yes, they can present with hematuria. Can it cause Guillain-Barré syndrome? Yes. Does it cause hemolytic anemia? Yes, it can cause cold type hemolytic anemia. Could this lead to Stevens-Johnson syndrome? Rarely, yes. Could this cause thrombocytosis? Again, yes. Commonly it is thrombocytopenia, but it also can lead to thrombocytosis, right? It also can lead to thrombocytosis, right? Okay, so we have discussed 10 true-false questions, right? If you kept answering with me, let's see how many marks you have got. If you have got, say, 40 out of 50, then if you multiply that by 2, you will get how many marks out of 100. The pass mark is, for most of the universities, local universities, 50. For international students, ERPM students and all, it's 45, right? So it's a good idea for us to know where I am, right? Otherwise, during the exam, you might feel, okay, exam is difficult, or when the results comes, you might think, oh, you might fail. So that we need to identify early and then act on that. Right. Okay, now
Dr.
we will discuss. Yes.
Sorry, I have a question regarding Stevens-Johnson syndrome. Like when you say that it's a rare complication, can we still call that a recognized complication and put that down as true?
Yes. Now, when it comes to this wording, MCQ wording, if they say common, the condition should be, say, acute glomerular in mycoplasma. Acute glomerulonephritis is common. If that is the case, if you get 100 children with mycoplasma, more than 50 should get acute glomerulonephritis, right? More than 50 should get acute glomerulonephritis, then you will say that it is common, right? Whereas recognized complications means if you even have seen one case report across the globe, then it is considered as recognized, so it is correct, right? Say you had...
Yes, sir. Thank you. And I have one last question. Is colostrum the same as formilk?
No. Colostrum and formilk are not the same. Colostrum is the type of milk the mother produced during first few days after delivery. Right. It is rich in fat. The amount will be just slightly more than a teaspoon, but that is good enough for the baby.
Right, and that so one doesn't have as much sugar as formilk.
No, it does not. Right.
Okay.
We'll do few SBS, maybe like in another half an hour, we will finish. Right. A 5-day-old neonate presented with vaginal bleeding. There were several pads with blood. She was a term baby and neonatal examination was documented as normal. She is clinically well. What is the most appropriate management? What is the most appropriate management? Yes. So term baby, otherwise well, presenting with vaginal bleeding. Yeah. What do we think? Any comments? Right. Now this question, right? This question tests our knowledge in normal neonatal conditions. right? If you read any standard textbook, you see benign neonatal conditions. Also, there will be a chart, significant neonatal conditions which need medical attention. So here, we need to know whether this vaginal bleeding is normal or not, right? If the examiner says that the baby is otherwise well and has got some vaginal bleeding, otherwise well baby, neonatal examination is normal, then we need to understand that this is a benign condition. Newborn babies, due to maternal high hormones, right? Baby also will have high amount of hormones, but then when after delivery, there won't be any more estrogen in the baby, then there will be something called withdrawal bleeding, like what happens in adult females menstruation. It is like a menstruation, right? So if you have that kind of bleeding in a newborn baby, we need to think it as, or we need to take it as normal, right? We don't have to do anything. Admit for further observation, no, nothing to observe. We know that it is normal. Perform coagulation studies, no harm done by doing it. But here we need to know, as we discussed that day, we need to ask from ourselves, why has examiner given this question to us? What is he expecting to test here? So here we clearly have to understand examiner's agenda is to see if we know that this is a benign condition, right? Now the other toxic way, very harmful way of arguing is, I know that it is normal, but really this could be a floating abnormality. Therefore, to exclude that, I thought of doing coagulation studies. No, Pudha, please don't think it in that way, right? If you have thought it in that way, that simply means that you did not understand the examiner's agenda, right? Because I am an examiner, because I have formulated hundreds of questions, thousands of questions, I know what is the art of making SBEs especially. So we need to understand, what does examiner expect here, right? Benign condition, right? The sad thing is, you knew that it is benign and you thought one step further and went wrong, right? If you did not know that it is a benign condition and you went wrong, that's a different thing, right? So this is a benign condition. Performing coagulation studies or doing a full blood count is not going to be helpful. We don't have to give any IM vitamin K, right? So vaginal bleeding is quite normal at this stage. That is what is tested here. So we need to know that very well. Next question. A neonate was found to have fever and jaundice at 48 hours of birth. She was born at term with birth weight of 2.8 kilos. On examination, she was active and crying vigorously. Icterus was there. And then what else? Icterus was seen up to abdomen. Her current weight is 2.4 kilos. Right. The investigations are as follows. Hemoglobin 16, WBC 10, neutrophil 55%, platelet normal, serum bilirubin is 250 is above phototherapy line. They have given it as a fact. Sodium 155, potassium normal, blood sugar 50, CRP 12, mother's blood group is O positive, baby's blood group is B positive. Right. The question is, what is the most likely cause for jaundice? Most likely cause for jaundice. Right. Okay, yes. There are a lot of comments, right? Now, if you analyze this question, so how do you analyze this question? So there is fever, jaundice, crying vigorously, and active. Active crying vigorously means that baby is healthy, right? Baby is healthy. It's very unlikely that baby has sepsis and then active. If the baby is septic, mother, the examiner will say, baby is floppy, less active, sleepy. Nothing is given, so sepsis is unlikely. Icterus is there. Current weight is 2.4, birth weight is 2.7. So what is the weight loss? 300 grams. Is that accepted? No. We expect babies to lose up to 10% by the end of 1 week. Right? So what is 10%? If birth weight was 2.7 kilos, that is 2,700 grams. 10% is 270 grams. Is that correct? Right? So up to 270 grams weight loss is accepted by the end of 1 week. Now, if you look at this one, this baby has already lost 300 grams. Am I correct? 2.7 to 2.4. He has already lost 300 grams. So what is the weight loss? Weight loss is more than physiological, which means there is a inadequate feeding going on. Right? Inadequate feeding going on. And I don't know whether you noticed this. What is this? Sodium 155. Right? So what is this? Hyponatremia. Hyponatremia. This suggests that the baby is dehydrated as well. Can dehydration per se cause fever? Yes. Dehydration fever is a very well-known entity. Right? And it can cause concentration of most of the chemicals, including bilirubin. So the bilirubin level will go up as well. Right? So this is why this baby is jaundice. So this jaundice is physiological and that is exaggerated by poor feeding. Right? The best answer should be exaggerated physiological jaundice due to breastfeeding failure. Right? So this is what has happened. Now the question is, why not other answers are correct? ABO incompatibility. If it was ABO incompatibility, we expect baby to start jaundice during first 24 hours. That is number one. Right? Number two, if it is ABO incompatibility, you can't explain why the baby has lost weight. Number three, ABO incompatibility doesn't cause fever. Right. Early neonatal sepsis, we expect baby to be lethargic, poor activity, right? You see CRP is slightly high here, right? CRP is high, slightly, right? But that can happen with dehydration fever as well, right? Inadequate breast milk is the answer. Galactosemia. Galactosemia is a rare metabolic disorder where child can't or baby can't digest galactose. There the baby will look very ill, septic, acidotic, lethargic, right? And galactosemia doesn't cause fever unless they got sepsis, right? And physiological jaundice itself will not explain why the baby has got this much weight loss and fever. So the answer should be inadequate breast milk, right? When we do SBA, I'm sure you must be doing group discussions, isn't it? Isn't that the way you do? Yeah, so you do group discussions. Now, when you do group discussions, it's a good idea to find out if the answer is this, and also to explain why other answers are wrong. Because with a slight modification, this question can be given again, then the answer is different, right? We always have to ask, okay, you are telling the answer is A or whatever, why not B? Why not C? Why not D? Right? So that is where the problem comes. That is where the experience matter a lot. Right? So we need to understand them very well. Right? Next question. 5 days old term baby with a birth weight of 2.8 kilos presented with vomiting, sneezing, jitteriness, lethargy, and 12% weight loss. Full blood count, serum calcium and magnesium were normal. What is the next line of management? Next line of management. Yes. Right. 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 Again, yes. Yeah, but I'm sure most of you must be in at least one of my WhatsApp groups, right? At least one of my WhatsApp groups, right? There may be few students here who are not in even one single WhatsApp group of mine. If that is the case, right, please join this. If you are already in one of the WhatsApp groups, please don't join this group, right? Please don't join this group, right? Absolutely, there is no benefit of joining multiple groups of mine. So you can just join this one if you are not on any WhatsApp group, right? Also, I have posted the Telegram link before. If you are not in Telegram group, please join that group as well, because I have only one Telegram group. You can join there because there are some bigger files which I can't upload into WhatsApp. And some of the messages I will only put in Telegram. So you can join that, right? Yeah, so that's about it, right? Okay. Right, so this question again. This is the question. Yeah. 5 days, term baby, birth weight 2.8 kilos, vomiting, sneezing, jitteriness, lethargy, 12% weight loss, full blood count full blood count serum calcium, magnesium normal. What is the next line of management? Yes. Right. So this question is slightly different, right? So when you see a baby with vomiting, we all know about vomiting babies, right? On top of that, if the baby is jittery, right? Jittery. Again, we know jitteriness could be due to hypoglycemia, hypocalcemia, right? All of those. Sneezing in a newborn is quite unusual, right? Newborn babies will not sneeze, right? We start to have sneezing due to multiple allergies. This and why not? What's it? But here, sneezing in a newborn baby is a bit tricky, right? So if an examiner has given sneezing, vomiting, jitteriness, lethargy, so this is the typical way how examiner will tell you this is neonatal withdrawal syndrome. Neonatal withdrawal syndrome or abstinence syndrome. This happens if the mother was on drugs, like say heroin, right, cocaine, right? If the mother was on those on those drugs, or even certain medication like antidepressants, right? Babies will get them through placenta, right? Once the placental connection is no more there, it is like a drug addict who does not have drug anymore. It's like that. Then what will happen? Baby will start to have withdrawal symptoms, right? Withdrawal symptoms. Now, withdrawal symptoms, to monitor withdrawal symptoms, how severe that is, there is a scoring system. Right? Each of the clinical feature will have own number of scoring, right? Vomiting will have, depending on how severe the vomiting is. It could be 1 or 2, right? Sneezing, jitteriness, is it? jitteriness during the rest, jitteriness upon stimulation, like that. How lethargic? Is he lethargic slightly? Is he lethargic to the point that he would not even drink any milk? Right? So depending on the level of these symptoms, they will give marks 1, 2, 3, like that. And then there is a scoring. If that score is above a certain number, usually it's 8, right? If it is above a certain number, then these babies should be treated as withdrawal symptoms with morphine. Or sometimes we give phenobarbital, right? Sometimes we give phenobarbital. So looking at this baby, you know that the scoring is definitely more than 8, right? We don't necessarily have to know the scoring system, but it is high. It is high, right? Then again, we need to think what the examiner's agenda is. What is examiner expecting to test in this question by putting this into the paper? So he wants to know whether we understood that this is neonatal abstinence syndrome, right? This is not simple reflux, right? So what are you going to do? Oral morphine, is that useful? Yes, you can give morphine, right? You can give morphine. Why not? Poor breastfeeding so that you can top up breastfeeding, top up. No, just poor breastfeeding doesn't cause vomiting, especially sneezing. Sneezing is odd. No. Anti-reflux medication can be given if you think that it is plain and simple gastroesophageal reflux disease. If examiner wanted to tell that this is gastroesophageal reflux, he would never mention sneezing, right? He would never mention sneezing. So that is not the answer, right? Okay, 5 days old babies, can we give things orally? Yes, right? Doesn't have to be IV. You can give oral medication, oral paracetamol, like that. Anything you can give orally. Reassure and discharge? No, this baby might die with a seizure. IV fluids? You might start IV fluids depending on the level of dehydration, but 12% weight loss per se is not an indication for IV fluids, right? So we don't have to choose, we should not choose IV fluid as the answer. If you choose IV fluid as the answer, examiner would think that you missed the scenario, right? You missed the scenario. So it's important to understand that this is neonatal abstinence syndrome. The answer is morphine, right? Whether it is given IV, subcutaneous or oral is something different. Only oral option is there here. So that should be chosen as the answer. Right. Okay. So this neonatal abstinence syndrome and all is very rare in other countries because our mothers would not be addicted to those medication. Whereas in Western countries, you will see neonatal abstinence syndrome in postnatal wards like dengue fever or asthma in our countries, right? It is that common, right? It's that common. If you see this question in PLAB, USMLE, AMC, straightforward answer is morphine, right? Morphine, right? Okay. Neonate delivered vaginally, all examination was normal except saturation on right hand 94%, right leg 93%. What is the next step of management, right? So this question, of course, doesn't have a lot to discuss, but we need to understand one thing. Newborn babies, when we have concerns, we check saturations on the right side and left side both, right? Right side and left side both. Right hand saturation indicates preductal saturation, preductal, before the ductus, preductal. Whereas left side saturation, left hand saturation indicates postductal, right? Postductal. If there is a difference between preductal and postductal saturations, especially more than 3% gap, please give me a second. especially more than 3%, say pre-ductal 97%, post-ductal 90%. So what is the difference? 7%, right? If the difference is more than 3%, right? In some guidelines, it will say more than 5%, but 3 will be the safe range. If the pre-ductal versus post-ductal saturation difference is more than 3%, we need to think this particular condition called persistent pulmonary hypertension in newborn. Persistent pulmonary hypertension in newborn. PPHN. PPHN. Which is deadly if you don't manage. Which is deadly if you don't manage properly. Right? Okay. So here you see saturations are not great. We expect babies to have saturation of more than 95%. Here, pre-ductal and post-ductal, both saturations are like 94, 93. But the gap is just 1. Right? This can go this way or that way. So in conditions where the saturations are between 90 to 95%, 90 to 95%, what we do is we observe the baby and repeat the test in 1 hour time. Right? Repeat the test in 1 hour time. Right. Whereas if the saturations are especially less than 90%, if the saturations are especially less than 90%, right, we need to start oxygen. Right? We need to start oxygen. Depending on the severity, we might have to admit those babies into neonatal unit. Right? If you are suspecting cardiac or respiratory conditions, we need to do chest X-rays. Right? And then if you suspect PPHN, persistent pulmonary hypertension in newborn, PPHN, if that is a suspicion, we need to do an echocardiogram. Right? Echocardiogram. PPHN. Echo. Right? Because PPHN came to discussion, if you get this question, which of following are true or false regarding PPHN? Right? PPHN. Post-ductal and pre-ductal saturations are significantly different? Yes. Right? What happens in PPHN? You know, in uterus or inside the uterus, pulmonary pressure is very high, isn't it? Pulmonary pressure is very high because the baby doesn't have any oxygen in pulmonary circulation in utero. Right? So pulmonary pressure is very high. After birth, we expect pulmonary pressure to come down. Right? We expect pulmonary pressure to come down. If that doesn't happen, what happens? Pulmonary pressure will be still high even after birth. Now that condition is called PPHN, persistent pulmonary hypertension. Pulmonary hypertension before birth is normal. If it is persisting after birth, that is abnormal. Right? When you have persistent pulmonary hypertension, what happens? That can cause reduced blood supply to the lungs because the pressure in the lungs is very high. Right? Then the baby will be hypoxic. So how do you manage that condition? We need to give pulmonary vasodilators. We need to give pulmonary vasodilators. Examples, oxygen itself is a pulmonary vasodilator. You can give oxygen. Any other pulmonary vasodilators? Nitric oxide. Right? Nitric oxide can be given. Also, magnesium sulfate is helpful to relax smooth muscles. All right? If none of them are working, what you do is you give the responsibility of cardiac and lung activities to a machine. Machine will take over so the heart and lungs can rest until they get better. That is called extracorporeal membrane oxygenation or ECMO. Right? We don't have many ECMO machines in our country. Right? Probably 1 or 2 to the whole country. Right? So if children get severe PPHN, if they do not respond to max sulfate, sildenafil, nitric oxide, then they would there's a likelihood for them to die. Right. But here this is not PPHN, but this can go to PPHN direction. So we need to keep an eye and repeat the test. Right. Okay. Question number 25. We have already discussed this during our last session. 5-year-old routine investigations. MOH found the heart rate of 80, which is normal. Blood pressure 90/60, which is also normal. Cardiac murmur at pulmonary area. Grade 2, normal heart sounds. No other abnormalities. Grade 2 murmur means there is no thrill.
Recording in progress.
We expect murmur to be at least grade 3. At least grade 3. Right. That's so we have discussed 5 SBS and how many 10 true false. With that we have covered a lot of topics in pediatrics.
Recording in progress.
Subgroups are like I put them as like online polls where you can select the answer, and then say after 24 hours I give the explanation. So try to do those questions in the WhatsApp group or Telegram group. That will be a good refreshing, right? Yes, I know there are local students and foreign students here. This will be beneficial for anyone. So we'll let you know when the next session is going to be, because